All right, so concluding Airway in this Airway lecture, it's been a culmination of a couple weeks worth of work for us. This afternoon, we will jump into the Airway lab and continue learning how to intubate and do all the fun things like tomahawk, nasotracheal intubation. We'll talk about digital intubation. And this is also going to give you an opportunity to learn how to do intubations in different areas, methods, and forms. Because you can't always rely on the standard equipment, the standard just orthodox way of doing things. You have to find a plan A, B, and C. So we left off with and there we go. All right, so I want to remind you that even the best ALS avenues does not eliminate the need for BLS airway procedures and hyperoxygenation. Why do I need BLS maneuvers to be perfect? What do you think there, Gabriel?
Be perfect. You can do small, simple things before you go advanced, because it can just be a simple obstruction of the tongue, or it can just patients. If you just remember, no airway, no patience.
All right, so no airway, no patience. So I could do some head tilt chin lift action, move that tongue out the way, maybe some simple suctioning, and I could actually cause a big change for the patient. Now, what about hyperoxygenation is important? Why do you think that's something that'd be a great idea? What do you think, Dabney?
You need to oxygenate patients before you try to do airway. They keep air in their lungs.
All right, so we have like a forced apnea that's going on, right? Mm-hmm. So the goal of pre-oxygenation is what? Okay, I like that. Give me some more.
Because even while the patient's not ventilating, the stagnant O2 that's in the lungs will diffuse. So you want as much in there as possible before you stop ventilating.
Very good.
Diffuse for as long as possible.
So we're saying the stagnant O2 that's left in that reservoir that you create will still diffuse into the bloodstream, and they will have at least some passive oxygenation occurring. So oxygenating and pre-oxygenating is vitally important, because you can get the O2 set pretty close to 100%. And for at least a 2 to 3 minute period. And it's going to be a lot harder to maintain that sat while you're trying to intubate. And again, we're not looking for you to be prideful. Give yourself a limit, like 30 seconds or a minute, whatever your limit is. My advice is to make it 30 seconds or less. And while you're intubating, hold your breath. Because if you're not breathing, they're not breathing. It'll be uncomfortable for both of you. So, how do you know that what you're doing is working? The old adage is what? Patients don't die and suffer brain damage because you didn't intubate. It's because you're not ventilating them. A lot of us, forego good ventilation for what? Running and jumping onto the intubation. You're jumping to ALS stuff before the BLS stuff is done. You're not pre-oxygenating. You're not setting yourself up for success. You're not preparing the field, as it were. So how can I make sure I've got good ventilation? What do you think? So good seals is what has to be perfect first. Good chest rise and fall. I like that one. What else? Capnography. Ooh, y'all are acting like paramedics now. Capnography. Ooh, PEEP valve use. I don't know if I beat y'all with that enough last week and showed you the video, but that is a abnormally good prospect, is having a PEEP valve during a respiratory arrest or a cardiac arrest. Explain to me what PEEP is, Dabney.
All right, so it's the thing.
All right, somebody besides that. All right, Sloss.
It's the thing that doesn't inflate your
Stop. Enough. I don't want to hear from you anymore. All right, Tyler.
Then expiratory pressure, and holds air in there.
Positive expiratory pressure, and it holds air in there. Very good.
Control it by
So what did we learn from the video last week, though? You saw the pig lungs. If you didn't have some type of physiological PEEP going on, right, they would return to level 0 and the alveoli would collapse. But once you added PEEP, it would stop the lungs from deflating completely, and you wouldn't have to start from level 0. Think about inflating a balloon. Starting from scratch on a balloon, it's kind of hard to get that thing going, but once it's going, it's easier to blow air into, right? Same thing applies to your lungs and your alveoli. Very good. Now tell me about positioning the patient. Does position matter? Yes, it does. Don't report me. So we have 3 axes, the mouth, the pharynx, and the larynx. So what you're going to want to do is to position the airway so you can have the greatest visualization of that glottic opening. Now, as we can see on the guy over here, right? We can see that there's a closure right here in the glottic opening happening, right? But if I just align his head and move this head backwards some, I can do what? I can open that glottic opening and visualize it. Now, every body is different. You got to find that sweet spot, which means if patient 0 has a big bullfrog neck, it might be way back here, or it might be a standard intubation where just, a certain tilt to do. But what you're doing is you're aligning the patient into more of a modified sniffing position so you can have the greatest visualization of that airway. Is visualization important for success in intubation?
Yeah.
You've all kind of played in the lab now, right? A little bit, except for Thornton, who missed class last week because she was trying to get a job at the greatest place on earth. So Thornton, who was missing lab next week, please. Will you please? So sniffing position is vitally important. So how do we do that? Basically, you're pulling that head back all the way and you're aligning the tragus of the ear with the collarbone. What is that going to do for me? Allow the glottic opening to be visualized. And remind me again, the Miller versus the Mac. Rath, tell me about the Miller blade. What is it actually doing inside of the airway?
It's actually directly lifting the glottis.
Very good. It's directly lifting the glottis. Therefore, the Mac's doing what there, Gabriel?
Back itself, you have to do a maneuver off one side and then keep it. Same thing as another, but you're doing an angle more towards lift it up.
Okay. I think I know what you're trying to say. So you're saying that the Mac blade is inserting into the vallecula, the little pocket behind the tongue and indirectly lifting the glottis. That's what he meant. I like it. And again, you don't have to verbatim say what I say. Vallecula. Very good. So you don't have to say what I say. I'm not trying to make a copy of myself. I'm trying to not make you me. I'm trying to make you, the paramedic version of yourself. Simple Sam. That's you. In my toolkit, he's the hammer. So positioning the head, let's talk about it. You move that head to the right position, then we're going to insert the laryngoscope blade. Now, everybody's going to have their own way of doing this. So I find that this part of the lecture is kind of like very subjective. Like me, I've got my own way to do it, but also it has a lot to do with your hand size. Some of you may have smaller hands, prefer the PD. Well, it's not even a PD blade. It's just a smaller blade with a decreased circumferential diameter. And for me, that'd be like holding a pencil versus actually holding something that I can articulate in an airway to achieve success in an intubation. Now, we said last week about intubation success rates in the pre-hospital having varying successes. Why is there such a variance in intubation success rates? What do you think they're not? Okay. So whether the provider is very practiced or experienced. The first time you did anything, go ahead, sir.
I think also just because of no confirmation also.
So not confirm you're actually in the airway. That's a good thing.
Instead of like just being one person, you have to ask your partner, like, hey, paramedic also might fatigue because you can move a patient, but also move the blades and the tube itself.
Okay. Environment. Well, we said last week during that former airway lecture that most of the airways we try and get, according to the American College of Anesthesiologists, is what? They're deemed difficult airways. There's no light. There's no way to pull out. There's no option to, consult expert help. It's you versus you. Honestly, there's no other way to do what? There's no backup plan. You are the backup plan. So can you fail at getting an airway? No, you have to get an airway some way, form, or fashion. Even if that means cutting a hole in somebody's throat, or in Georgia, using a needle cric and stabbing through that cricothyroid membrane, which, if we have time today, I have mannequins in there we can practice that on. We can practice needle cric, we can practice surgical cric. Again, if somebody has not moved my stuff. Chest decomp will wait for chest trauma. You know what? I've got that mannequin. We might as well do it today too. And just redo it in trauma. So what are some other things that can help increase your success rate? Back in the day, we called this the Selleck maneuver, but it's now graduated to what's called the burp maneuver. So the Burt maneuver is backward, upward, rightward pressure. So basically you're going to grab that patient's larynx and that part of the trachea, and you're going to actually force it up to where it can be visualized. Have greater visualization by having your partner actually grab that thing and like shove it up there so you can actually see it better. Believe it or not, this works very well. Very well. Also remember that laryngoscopes are made for what? Right-handed people. The light itself is on the right side. So you'll need to insert into the left side of the mouth, sweep the tongue, come center line, and then we're going to lift up. Remember, it's cheers, not beers. Don't rock back. If you rock back, you're going to damage some teeth. Last week, we did not have the tattler, but John and Cobb there, they did some MacGyvering, and they actually stole the mouthpiece out of one of those broken mannequins, and we kind of pretty much, just took him for parts. So now we've got the tattler. So some of y'all are not going to be able to get away with it this week. You're going to be bucking teeth. So place the curved tip of the blade in the vallecular space. Curved tip. What was that again, Gabriel? What blade was that?
Oh, the back.
The Mac. Turn of the Mac. Very good. So lift it up directly. So the straight blade goes directly under the epiglottis. There are benefits to both. Obviously, as you play with it more, you're going to develop a propensity to have a favorite. I was always a Mac 3 guy, still am to this day. What you got?
That's what I do is I use the max.
What do you mean? What do you do? You're an EMT. What does that mean?
Boom.
I don't know what you mean. Explain.
No,
I am recording.
so could you use a longer back to get the middle effect, but you didn't still be able to?
Could you use a longer blade? Hell yeah, you could. No. You know what? So if you look at the Mac 4 versus 3, I mean, there seems to be a huge size difference there, but with the Miller 3 and 4, there seems like to be a couple millimeters difference. So with those two, no. With the Mac, maybe, but then again, you might overwhelm their airway structure. And also what you didn't catch last week was that blade tip. Remember the little trick I did with your hand? And how damaging it can be? Let me show you that real quick. That way you have a, So again, you have to choose the blade for the airway. And again, picking this huge size blade, you might overwhelm that patient's airway. Like look at Dabney's little mouth. Look at that little thing. Say ah. Take him all day. Take him all day to eat one donut. Have to eat around it. taking little mouse bites. So look at this thing though. That's going to overwhelm his little airway versus Sloss who could deep throat this thing. You sat up front. That's what you get. But you can tip different bodies, different folks, different strokes, find what works for them. Like if you've got like a 15-year-old kid, don't be jamming this thing down his throat. Look at that. Look at this. Make some smart decisions on that. Now, what about bougie? What about bad and bougie here?
Very convenient.
Very convenient. What was that study I gave y'all last week? What did it say?
It increases by
96%. IMED did a study using a bougie, increase your first pass intubation success rate to 96%. That's pretty good considering that a lot of places have considered getting rid of intubation for the paramedic scope because of the poor success rate. Why do you think other places have poor success rates? What do you think they're staffy? I'm going to that Mexican place again today.
What?
Sorry.
High acuity, low frequency skill, people don't train on it.
They don't train on it. Is this a high acuity thing that we're doing, intubation?
Yeah.
Based on where I work, and I've said this a few times to you, when I was in South Georgia, I'd probably intubate 3 times a year. Here in Atlanta, there was nights I intubated 3 times a night. This is paramedic playland up here. Greatest and funnest time of my career. And I tell you, working in Atlanta, if you guys are missing so many opportunities to really just flex and use your skills and be sharp at it, man. It's really on you. How good you are is really how much you put into it. How much you put into it. So there's an old saying, the more you sweat in training, the less you bleed in battle. What does that mean, Baker?
If you do more in practice, when it comes down to the real thing,
Pretty much got it down, right? All right, there's a whole nother slide about the gum elastic bougie. Basically, what you can do with the bougie is you're going to use it to intubate with first, and it's easier to articulate, to move in that airway. And you can intubate with it first, and then just slide the old ET tube over it. Now, what about picking the ET tube? How do you pick an ET tube? What? That's a good idea. Actually, hold it up to them and measure where you're at. So most women are about a 7.5. A smaller woman, probably like a 7. Most men are a 7.5 or an 8. Shaq would be like a 10. You know, but don't be trying to give a 10 to little Dabney over there. It'd be like going all the way to his toes. If you give a 10 to Slauson, you just swallow it.
I knew it.
You knew it. At least you knew it. I'm consistent. I'm a lot of things, but I am consistent. Why don't y'all complain about it? File a complaint. Do it.
You said women are what? 7.5.
7.5.
7.5.
Is there like a actual way to measure that? Not like,
Well, with peds, we have actual ways to do it. So like age plus 16 divided by 4 is a good formula for peds. And then you can always use their pinky finger, and you can always use the diameter of their nair, so their nostril. And as far as an adult goes, as long as you got, at the end of the day, as long as you got some type of plastic straw going from the top of their airway past their glottic opening, and you inflate that balloon, it should still be pretty much okay. Now, there is too small a tube can let air pass through and pass by. So you want it to be large enough to where it will fill that space, and then when you inflate the cuff, it will then cut off and protect the airway from any kind of aspiration. As long as you're not going past the carina and you're inflating both lungs, it should still be okay. Make sense? What is the carina? Remind me again. Bifurcation of the trachea. So where it goes left to right. Very common mistake a lot of paramedics make is they perform a right main stem intubation. What is that, Dabney?
They're going past the lung. I mean, they're digging into the lung. They're really deep inside of there. They're hitting the lung.
So basically, you're kind of right. I mean, ish, heavy on the ish. So we got 2 lungs. There's a split in the road. As you intubate too deep, you will push that ET tube into the right lung. The left lung will not be inflated at all. So it's only right lung, right main stem intubation. So this is why we do tube confirmations with capnography. We listen to both lung. This one ain't got no lung sounds. Patient sats are still kind of dropping. You know, and this is why we do all these check techniques before we say we've got this intubation. Capnography being the most reliable and accurate, seeing the tube pass through the cords, condensation in the tube. We got lung sounds. We listen to gut sounds, and we also can use an esophageal detector device or whatever your service uses. But my advice would be that any intubation you get, you at least document 3 methods that you used to confirm the tube. Anytime somebody moves a patient of yours, like even if it's from stretcher to hospital bed, confirm the tube before, hey, I'm just going to confirm the tube. Because I've had a nurse try and come at me one time, several times actually, about, you know, the intubation and the success. And it was one time they snatched that patient over before I could even do anything. And she's like, he was using the gut this whole time. And I held up this big strip of CO2 monitoring capnography. Actually, no, you just yanked it out because you pulled him over before I said I was ready. Have fun. So, no. Nope. So always do what? Pick the tube size, verify the tube, but also when picking a tube size, pick the one you think it is, but then go ahead and grab the size above it, grab the size below it. That way, just in case you're wrong, remember what we said last time. Think about it. You need to have a plan, but when you go back to the airway, don't do the same exact thing you just did. What should I change? What do you think there, Thornton? Technique. Okay, change your technique. What else? Positioning. What else? How about the blade? Do not go. I've seen a lot of paramedics do this. They will enter an airway and then miss the tube, and then they will grab and go back to the same airway with the same tube with the same size ET handle with the same exact blade, have not changed position, have not done anything different. They expect a different result. Change your blade, change position, move the patient, apply the Burt maneuver. What was the Burt maneuver, Gabriel?
Backwards, upwards, right, forward.
Backwards, upwards, rightward pressure. Very good. We used to call it the Selleck maneuver. Either way, just grab that thing and push it up so I can see it. And you'll see this afternoon when we go to lab, how effective that thing can be. So let's talk about a troubled airway, bro. Are you missing an airway obstruction that can be resolved through abdominal thrust, or is there something in the way you need to get the McGill forceps out? Is it something in the way? How would you know? When you try and bag the patient, what kind of resistance are you getting? What does airway resistance mean, Sloss?
Something obstructing the airway getting into
Okay, sort of. So the ease in which the patient can be bagged, it should be like easy bag, right? But if you're having to squeeze that bag hard, it means that air is hitting resistance. Something's in the way. So in the case of a deep tracheoform body, worst case scenario, you got one pipe. The trachea is a one conduit. If it's blocked, you die. Worst case scenario, what can you do?
push it down.
Push that thing on down. That's going to create a septic, probably pneumonia issue for them to deal with later. But hey, airway is the most important thing, right? You can live now and deal with antibiotics and something else later. Would you rather live or what? It's not something I want to do. It's definitely not something I want to admit to, but I have done it, and they did live versus, not living. So a no. Do not pass the tube down the barrel of the laryngoscope blade. This is not a guide. It will obscure your view and could actually put you into what? The guts. It'll put you in the guts. I just ate. Disgusting. So the blade's not designed for that. What is this thing meant to do? It is a laryngoscope. So larynx scope. So it's meant to just view the glottic opening. And again, some of you will not even carry this old iron sides here. What will you have? Some of you will have old fancy boys. We'll have this old video laryngoscope that sits on your engines that you don't even use. Oh my. Fancy. Woo. Also, last week, I didn't feel the need to mention it to you because, I was otherwise engaged with other things. But the reason you weren't successful with this is because you'd have to drop tube size to use it because of the size of this thing. You dig? So if you're going to play with it today, drop a tube size than what you were using. You'll see it be a lot more successful.
So they can't be used with surgery or something.
Well, there's only so much room in the mouth. There's a finite amount of space, and you guys were having trouble using it last week because that thing is huge compared to this. It takes up a lot of space.
So are there different size video laryngoscopes?
For the King Vision, there's two sizes, a 3 and a 4, and they're all kind of curved. But I'm sure that there might be other video intubation stuff out there that is, different sizes, may even have a straight blade. Just depends. I only know what we got here in Atlanta that sits on engines and is never used. I'm looking at you. Stacy.
I asked Lowndes. He said that there's not been one there since he's been.
Lowndes doesn't need one because he's good. Lowndes can close his eyes and intubate. Doesn't need no video laryngoscope. Some stations have them, some don't. All of them did have them, but like last year when we had this conversation, because there's nothing new under the sun. We have similar conversations every year. I promote, hey, let's talk about getting the PEEP valve, guys. The whole thing I do, and then they go and look for it, and they find, it's in the back in the supply room. Oh, it doesn't work because the batteries have rusted out in it. That's the conversation every year. So here we are. What are intubation killers? Remember to hop. Hypotension will kill your patient. Oxygenation issues will kill your patient. pH will kill your patient. So hypotension, how do I avoid that? Hyperoxygenate's a good idea, but also monitor their blood pressure. Or is the blood pressure falling? Why? Because they're about to go into cardiac arrest. A lot of times when somebody's in respiratory arrest, they're not breathing. They'll Brady themselves down before they go into the arrest. because the heart is not getting what it needs. So it's going to try and reduce the metabolic rate in which it's consuming oxygen and nutrients. And then it's going to just break itself down to an arrest. Oxygenation kills. Hypoxia will kill. Why? Because the body needs what? The cells need water, oxygen, glucose. Cells make tissues. Tissues make organs. Organs and tissues will not work metabolically. So if the body's not getting oxygen and it is hypoxic, the body will switch to what type of anaerobic metabolism and create lactic acid. The pH of the body, pH, will do what? Drop and become more acidic. And what we learned last week about the acidic environment, Thornton, and the hemoglobin dissociation curve with that right shift. Oh, you don't know? You weren't here? Interesting.
Being transported and dropped off the room, okay?
Okay, so the right shift causes a decreased affinity for the oxygen molecule, and it will not even deliver the oxygen molecule to the right spot. It'll drop it off somewhere else. It has decreased affinity. It never makes it to its target. Very good, Walker. Thank you for being here last week. Next slide. Airway management does not automatically mean intubation. You know, as paramedics, and even as your instructor here, I've been kind of pushing you hard about making sure the ET tube is what you get. I even made you write a paper about iGels versus the ET tube. That was only to give you a perspective about how much better an actual ET tube intubation is. However, there's a time and a place for a rescue airway. All right. There's a time and a place. There's a reason we have it. There are alternatives, such as a combi tube, an LMA, a King airway. They are accepted. They are advanced airways. They are supraglottic. What does that mean? A little bit. Talking to you. Just can't remember your name. It's okay. I know. What was my question? What does supraglottic mean? Very good. Above the glottis. ET tube just goes below the glottis, and you can inflate a balloon and protect against aspiration and have full alveolar recruitment versus the supraglottic, which goes above the glottic opening and does what? Still inflates the lungs, but just not near as much. iGel does count, I guess, but I want you to know that I've been picking at you a lot, but there's no harm to the patient and no shame to your game if you just couldn't get the airway and you did an iGel instead. That's okay. What is half of nothing, Dabney? Nothing. Half of something. Still something. I don't mean run to the iGel as an easy button every time, but I do mean that at a certain point and place and time, you may have to go to an iGel. It ain't about you. It ain't about your pride. As a paramedic, I want that ET tube, brother. I want it in. I want to look good in the ER, secured airway. Look at my capnography flowing. We want to present a good packaged patient, right? That's not always the case. You can't always present perfectly. You know, you just do the best you can. And you did try. You tried to intubate. Sometimes it don't work. So the thing about this we also have to remember is that regardless of what airway you got in there, you have to go back and check on it. Regardless of what airway you got, it requires continuous monitoring and repeated reconfirmation. So we said last week the 3 pillars of airway management is what? Early detection of problems, aggressive management, and then constant reassessment. What does that mean? We're going back and checking to make sure that we're still at 21 centimeters at the lip. We got good capnography going on. We've got chest equal rise and fall on both sides. We are making sure that the patient is actually improving and not getting worse. We're making sure that we don't have increased airway pressures. We're making sure we have not popped a lung. Continuous monitoring and continuous constant reassessment to make sure that it hadn't dislodged. You've rode through Atlanta now, right? You've hit potholes so hard that it probably cracked your back like me. It's happened to me before. The patient has pretty much extubated himself by a pothole. Hit a pothole hard enough, that tube shifts. So just guaranteeing and verifying. How long does that take you to do?
If you have ETCO2, You just look at the monitor.
Look at the monitor. Yes, it takes all of 1 second. Like I'm still there. I can see from right here, the patient's still at 21 at the lip. Not a biggie. Plus, if you use a commercial tube holder, it holds it in place usually. So there's a lot going on there, but going back and rechecking. So when we go back and do a reassessment of your secondary assessment of your patient, what are we looking for? Go back to LOC. Why would I check LOC on an intubated patient? What do you think they're not?
Oh, you create that LLC.
LOC of an intubated patient. What's a good idea? Why would I do that? Okay. You do a good intubation and good oxygenation, they might start improving a little bit too much and start waking up. What are they going to do? Extubate. So I go back and check LOC to make sure they're still down for the count. Because if they start to wake up, they're going to extubate. So LOC, airway, we're checking that again. Breathing, make sure it's adequate. Making sure that the patient's actually improving. Does their color improve? Is their SATs going up? Is their blood pressure staying at a normal range? Circulation is what? Circulation, we have the issue of what? We got to make sure that the blood pressure is actually improving, that cardiac output is managed and making its way up, that we're meeting the metabolic demands of the body. How do I gauge cardiac output? Do I just look at a ED, like a cardiac monitor? What do you think, Gabe?
Do that one more time, sir. I see what you're asking.
Sorry, it's okay. How do I gauge cardiac output? Do I just look at the EKG?
You can because of the MAP.
Well, let's pretend that EKG monitors lie. What is the EKG monitor telling me other than what rhythm they're in and how fast the heart's beating or presumed beating?
Well, you can't really, it's just a machine, you can also mess up with it. You like your patient.
It's a machine, but also, my friend, let me give you a piece of advice. That machine is only reading electrical waveforms. It ain't measuring mechanical output. You know what you need to do? Actual pulses on your patient to make sure they match that monitor. Also, another measurement of mechanical output is a blood pressure, a manual blood pressure. Those pneumatic cuffs, they be lying. I don't trust them. You can leave the regular manual blood pressure cuff on their arm just like you would the pneumatic one. Leave it there and then go pump it back up and listen and get a real blood pressure again. They're more accurate. Why would you sacrifice accuracy for convenience? Tell me about that, Tyler.
Why would you sacrifice accuracy for convenience?
Yes.
You take it now.
I just want it right now. It's your money. Get it when you need it. It was a trick question. You shouldn't be sacrificing accuracy of a blood pressure or pulse for the convenience of a monitor doing it for you, but there are medics that do.
What is a different situation? It's like, you have to do that.
I don't have to do anything. I'm the paramedic. I run this show. This is my patient. Why would you have to?
You think, for example, say you're in trouble to, very critical patient. You're going like.
By yourself.
Basically
Still
yourself,
wanna come back.
You want to sacrifice accuracy for convenience still?
Also, but that time,
But if you have, if you're trying to do all the things by yourself, you gotta use your tools that are available.
Welcome to being a paramedic. You know what being a paramedic taught me, especially in Atlanta?
One way show.
Trust no one,
One way
one man show. And even if I had a great partner. My partner at G Unit was amazing. He still is out there getting it. But who's ultimately responsible for that patient is me. And if the patient deteriorates and I'm back there alone, he's still got to drive. I'm by myself anyway.
That's what I'm saying, you gotta use the tools that are available to you.
We're there.
So what if I know that cuff is like 40 points off? Can I trust it?
You know it's off, but then.
Well, I can tell you that the way them things are done, the calibration on the pneumatic cuffs is supposed to be done every 6 months, and it's not done but every couple of years. I'm telling you now, I know that they're off. I know that they're off. Can I sacrifice convenience for
No.
None of that.
the patient's critical? They're deteriorating. Should I just, all right, use the automatic cuff? I have other things to do.
Yeah, but if you use a man and you're trying to get a basis for blood pressure to know if you can give nitro or not, and you know it's off.
So that's a good point to make.
Better one and you. There's the battle, you don't have time.
I could change my treatment. So let's say the nitro that you just brought up. Nitro, I can't give it if their blood pressure's under 100 systolic, or in some places 90 systolic. That could be the difference in me giving a treatment versus not. It needs to be accurate. I know it's going to feel agonizingly slow. And again, you're going to be the paramedic yourself soon, so you do what you want. It may feel agonizingly slow, but it is 100% accurate if I do it right. Slow is smooth, smooth is fast. Do the manual blood pressure, then you could base your treatment modalities off of accurate assessment. Accurate assessment. I know it sucks. I want to just hit a button and be like, I got other things to do. Look at me, look at me. But it could affect my treatment plan. Am I giving a bolus or do I need to give a pressor? Can I give the nitro versus not? You know, are they deteriorating or are they actually improving? Baseline vitals are meant to do what? To trend, improvement, deterioration, stability, instability. I can't base these things off of inaccurate readings. I don't trust the thing. You do what you want. You be the paramedic, but when it bites you on the butt, I expect an email apology. I'm trying to give you the tools that I didn't have because there was a couple times that I relied on it too, and it was dead wrong. Matter of fact, I told you I picked up a Grady shift 2 weeks ago. I was sore for 2 days, and that was the first shift I'd worked physically in a long time. And I told you about the patient that was in. She called for chest pain and blah blah blah, but the blood pressure that the guy I was riding with took off of the pneumatic cuff was like 130 over 90. The manual one I got was 230 over 130.
So you didn't try to verify like it's just the pulse and that check or anything?
He was relying on that cuff being right. And the thing is that she was starting to have trouble breathing because she was having flash pulmonary edema from the CHF exacerbation that she didn't even know she had. So that's a great example of why you should take manual vitals. Good segue. I enjoyed that. Ventilation. I don't think that bears beating on. Ventilation really for adult need to be doing 10 to 12 breaths a minute. Child, 12 to 20 breaths. Patient in cardiac arrest, 8 to 10 breaths. So that's about a breath every 6 seconds. Making sure that you have equal chest rise and a quiet epigastrium. Checking for the ease of ventilation. Remember, if you ain't got a seal, you ain't got no airway. You got no airway, you got no patient. How can I predict? Excuse me. How can I predict a difficult mask ventilation? How about bones, man? Beards, obesity, no teeth, elderly, or snorers. I'm gonna give you so many mnemonics this year, so it's not gonna be funny. How about bones, beards, getting away from a good seal, obesity, old frog neck, no teeth. You must have good dentation for a good seal. How about people over 55? Why would that be a problem? Dentures could be a thing. What else? How about that?
Your mouth breathers?
They're not firemen. They're not mouth breathers.
They were stiff. They don't have
They're very stiff. They don't have that neck mobility. Like you can't move grandma back like that because her bones have done calcified. And also a lot of them have that kyphosis form. What is kyphosis? Hunchback of Notre Atlanta. Snorers. Anybody here snore?
Oh, you turned into this. Breathe.
You're recording?
Yeah.
Yes.
I say hi to Harmony.
Walters. Walters definitely snores. He was snoring a minute ago. So if they got 2 or more of those right there, they're going to have a difficult intubation. Excuse me, bagging. Now, what about a mnemonic to help me with placement of an endotracheal tube? How about check it?
Oh, damn.
Just check. Oh, you wasn't done? I'm sorry. Let's go back. Let's go back. Excuse me. I'm so sorry. Bones. You ready for the next one? Everybody good? All right. How about we check the airway, capnography, heart rate increase, equal breath sounds, condensation in the tube, and a kinetic chest. So capnography is the most reliable indicator that you've actually gotten the airway in the right spot. Capnography is extremely reliable. You cannot get CO2 from the guts. Heart rate increasing is a great indicator that you've actually got the ET tube in the right spot, because if the lungs actually start getting oxygen, the body will start to be like, much better. Let me increase the heart rate to increase the metabolic demand. Remember, we said it will Brady down if it starts getting hypoxic. Why? To conserve energy. Now that it's getting the stuff it needs and wants, it'll increase the heart rate. Equal breath sounds is a great one too. You're not going to get equal breath sounds if you're where? In them guts. Now, why about condensation in the tube? Air's going through. When you breathe out, there are droplets. And some of y'all with hot breath will create that condensation. Now, what about a kinetic chest? What does that mean? Chest rise and fall. Not going to get a whole lot of chest rise and fall if you're in the guts. Remember to check your ET tube.
Can also do the esophageal check.
Yes, you could. If you carry it, if you got it. Another thing you can do, is everybody ready? Is visualize the tube passing through the vocal cords. Visualize the tube passing through the vocal cords, okay? So some people be like, I got it, man. No, you put it in a tube, but it wasn't in the right hole. Oh, wrong hole. You gotta make sure you're in the right hole. Norbit. You can't sneak one past me. I've watched too much TV. So visualizing it going through the vocal cords. How do I recognize and identify the vocal cords, Dad? You know what they look like? Like that? What's that? A little what? Hang on, let me pause and you can tell me what I said last week. All right. So yes, it does look like one of those things we discussed. Exactly. So why would we auscultate? What does that mean to auscultate? Listen. What am I listening for? Lung sounds? So unequal breaths would tell me what? You're in the wrong spot, bro. Wrong spot, bro. Right main stem bronchus placement. We talked about what that was. What was that, Thornton? Okay, so it's too deep, right? Careful, don't go too deep. If you go too deep, you're only going to inflate the right lung. The left lung needs it too. What you got, sir?
So with right main stem and pneumothorax, no, it's that. It's not this.
Go back.
Oh, this is my right, my bad. That, when I was referring to that. Could you actually be correct and mistake the right range stems for if you have pneumothorax?
Are you saying if I have absent sounds on the left side? I think you got a good point here. Let me see if I can work it out.
Yeah, you got it.
You're saying maybe I've actually popped the left lung, but I'm mistaking it as the right main stem because I just intubated them, but I popped the lung instead.
Yeah.
You could actually mistake that.
Or
Yeah, like if you got an increase in one lung.
patient that a chest trauma, they might have already have a left.
Yeah, on one
So a
side.
patient with a chest trauma that might, I'm not, that, okay.
You
I'm-
might already- but when you're intubating,
You
you
probably
don't
don't
hear
get it
what
right.
sounds. You might mistake that for being in the right part.
That's a good point to make. And if I repeat you, it's only for the benefit of the recording. So if I have a patient with a trauma that may have already had a pneumothorax, before I place a tube, I should have already caught that. Because my assessment has to dictate my care, right? So as I'm checking airway, breathing, circulation, be right with you, I should have already caught they're having a missing lung sound on one side. So yes, but also no. Because I should have caught that.
Both lung sounds that you would need to do a intubation anyway.
Say that again.
Would they have had lung sounds even if you had to do intubation? But we just talking about pneumothorax with no intubation.
Okay.
You would hear it, right?
Fair point. Fair point. So if we found a patient that was experiencing a possible chest trauma and in the assessment reveals they're having an airway issue and they need to be, they're apneic, we need to go ahead and start with the intubation protocol. You would still hopefully bag them first and find the lung sound missing. It's just like, oh, you ain't breathing, here's a tube. We still would want to pre-oxygenate them first get some air circulating, and then we would want to intubate them. So yes, but also no. That's a good question though. And it's very possible to mistake a right main stem for a pneumothorax that you caused or didn't cause.
It'd also be persistent too, because like if you thought it was a main stem bronchi placement and then you adjusted the tube and then you still are having the issue even after you repair by placement, that would be the obvious.
Good point. I'll repeat what he just said, is that you can verify if it was a right main stem or not by just pulling the tube back a little bit and making sure it wasn't a right main stem. Mr. Walker.
But I took from what he could admit this or not, but this, I'm gonna switch it up. So.
He could have meant that or not.
Yeah, I don't know if you think what I'm about to ask or not, but yeah, I'm not. I'm saying. So what I took from what he's saying is, if they have an injury to the left lung,
Yeah.
and you purposely go into the right lung to make sure you're ventilating. That's what I was talking about. Y'all there all the way around. I'm talking about that. Like, can I purposely go there because I know that there's an injury to the left, so I'm gonna purposely go here.
I mean, you gotta find out what the injury that caused the ambulance first, because if it's a pneumo, then you're gonna have to be afraid. Because if you ventilate while they have.
Very loaded question. So ventilating an already popped lung over there could do what? We're going to create a tension pneumo versus a simple pneumo. So yes, if you needed to, could go to one side, but also with creating the tension pneumo, you can create a port for air to flow out with that needle chest decompression. But I don't know what the book's telling you. But first thing first, a needle chest decompression, it's kind of scary to do. You're about to stab somebody in the chest. It's, kind of nerve wracking. Secondly, it only buys them maybe 10, 15 minutes at max. The first time I did it was in Montezuma, Georgia, Macon County. Woo, many nights. Yeehaw. Guy had flipped his four-wheeler, bad pneumothorax, and it was tension, obviously. I could see his JVD across the room, right? He was having trouble breathing. He was turning blue. I didn't see any tracheal deviation as they said I would. I'm like, the book says no, but he was having bad trouble. So I stabbed his chest and he started feeling better. And then I pulled the needle portion out. What happened is the lung reinflated and did what? It bent the straw catheter. It only bought him 15 minutes. And from Montezuma to Macon, the med center, about an hour drive. So what I had to do again, right beside it, bought him another 15 minutes, reinflated, bent the straw. What I do next? So I don't know. You're thinking in your mind, the book's telling you it's a fix all, right? It's not. It is a buy them time between 10, 15, maybe 20 minutes, depending on their physiology and a bunch of little factors, their variables, but it ain't going to fix everything. It's going to buy them a scruple of time. So for you, with what your question is that,
Okay, so this is what I'm saying. So along with the decompression, right?
yes,
So instead of continually trying to inflate both of those, just decompress that side and inflate one side. That's what I'm asking. That's what I'm trying to ask.
I'd call for orders to do that just to make sure somebody's checking you off on that being okay, because we don't have protocols for that. I can see your reasoning and why you'd want to do it, because you don't want to make the left side any worse, right?
Yeah.
But at the same time, that tissue over there is going without oxygen. At the same time.
Still have had chest rides on the right side. Like, are we just talking about a created pneumothorax with this? Because on a simple pneumothorax, you would technically still have.
Yeah, so my question was that, not that I created it, but that's the situation.
That they had one.
Yeah, that's what I had.
So whether you created it or not, you have to deal with it. If they got a popped lung, you have to deal with it. The popped pneumothorax can become a tension pneumothorax if you keep increasing thoracic pressure, because now it's not negative pressure they're breathing off of, it's positive pressure because you're now intubating them and you're now forcing air in there, which has a great propensity to increase that intrathoracic pressure. So you could make it way worse.
Yeah, but if you decompress that one side, but you only focus on the plate with the other side. then you don't-
It could work. It could work. Physiologically, it sounds like it'll work. But again, that sounds a lot like practicing medicine without a license. So I would call, tell them what I got, and have them approve it. That way you can come out smelling like a rose. That's you covering your butt. I see where you're going, but you're going to want to make sure that you've got somebody's approval. Per Dr. Dingleberry, we got that going on. That's a good question, a good segue, and also a good spot for us to segueing into how to secure your tube. So as we see on the board, this is called a Thomas device. Or you could call it a commercial tube holder. It's got a built-in bite block. Why is that important for a patient with something in their mouth?
So they don't.
So they don't bite your God blessed tube, because they could clench their jaw and do what? Obstruct the tube. Not just bite it to be biting it. They could obstruct the tube by biting down on that tube and obstructing airflow as you bag them. It sure is hard to bag this patient. Well, because they're biting the tube. That's why you want to use a commercial tube holder device. Now, we talked about once you get the intubation and you've confirmed it and all that, you never take your what off the what? Hand off the tube. Why? That thing could flop out. You ever had an IV stuck and then it flops out because somebody took their hand off of it? Yeah, it's not the coolest at all, is it? So never take your hand off the tube. Get yourself a commercial tube holder device. And when you set up your intubation equipment, make sure that is a part of your setup, please. And thank you. So never take your hand off the tube. There it is, rewritten. Securing the tube, note the centimeter marking on the ET tube. What does that mean, Sloss?
So their teeth means the little indication. Like
Okay.
21.
So 21 at the tooth is great. Now let's talk about tube depth. How deep should you go, Dabney? I know it's an appalling question to ask you, right?
You should go-
As far as I can, of course.
You should go,
To the what? Okay. Is there a formula that I gave you last week to maybe help you remember how deep to go? And remember, if you can't knock the bottom out, you can always tear the sides up.
Age
Yeah.
plus 16 divided by 4.
no,
That's for children.
That's for pediatrics.
So for depth, we're going to do tube size times 3. So let's say it's a size 7 tube times 3, 21 centimeters, 7.5, 22, 23, something like that. Something like that. As long as it goes past the glottic opening and doesn't go past the carina, you should be in good shape. We talked about having a built-in bite block to minimize head movement. Also, you might want to learn how to intubate while there's a C-collar on. Sometimes those guys that wear the Maltese cross on the uniform, they get there first. And that's not always good. Why? Well, he's a trauma patient, even though he's bleeding in his airway. I think I told y'all this last week. I had a guy with a Lafort fracture across his face. He's bleeding his airway. And I get there and they've already backboarded him and put a C-collar on. Good job, right? They've backboarded this patient who's bleeding into his airway. Interesting, right? What you got, sir?
So what would you do in this situation? So you want them.
What did I do in a recording? What did I do like in real life?
Really,
Yeah.
like, like, for example, usually the protocols.
All right. So what I documented is not what happened. I checked his neck real quick, make sure he didn't have any kind of cervical step offs. I suctioned him, turned him on his side, made sure I could clear the airway manually. And then I sedated the crap out of him and I then manipulated his neck to get that tube, because if you don't have a tube, you don't have an airway, he's going to die.
So what would you do if you were fired?
As a fire medic, what would I do? Everything that I would have done as a Josh medic. Oh, damn. I'm on recording.
You already saw that.
EMT arrive on scene, what did they want you to pay?
EMT can clear that airway with suction and keep it open and then, try and bag the patient through that stuff. Worst case scenario, we can put air through fluids with CPAP or positive pressure. Your job will be to keep that airway clear until a paramedic can come and take the airway. You need a secure airway. This is not one of those jobs iGel can fix. This is a ET tube job. So making sure that you can have that ready for me when I get there. If you're just an EMT crew, but there was medics there. Because believe me, I looked around like, all right, I'm seeing the patch, seeing a patch, seeing a patch. But what we need to have happen is clearing the airway, suction, manual clearance by, again, if they're on a backboard, you can turn them over and clear that airway. Especially if you've got Grady straps on. Like if you've ever had real Grady straps, you can pick that person up vertically and move them and blah, blah, whatever you can do. They're good. So I would say that what I did on, in real life was that I took the collar off and I made sure I could get in that airway. I'm not trying to cause the guy any kind of harm, but if I can't get this tube, he's going to drown and die. You know what I'm saying? And I ain't telling you to do that. Once it's on, blah, blah, blah. I'm telling you what may or may not have happened. Allegedly may have happened. That airway is key. That is king. No airway, no patient. And again, that fracture, there's blood going actively. So I actually had to suction while I'm intubating. It's called the salad maneuver. I'm hoping I can borrow one of those from our friends across the pond over here in Atlanta. They have 3 of them. If not, then I'm just gonna have to, go feed Dabney a bunch of, spicy foods, and, we're gonna have to intubate him and make him puke. What you laughing at?
I'm eating healthy.
You're eating healthy? It doesn't look like it.
I started that. It takes a little time,
All right. I ate healthy today. It
Burrito.
was delicious. It was a wonderful burrito. All right, so try and minimize head movement. So you always want to do what? Protect who?
Yourself.
The tube. So this is an over exaggeration just a bit, but what is that medic doing? He's
Kicking Buddy in the nuts.
back up. So he's protecting that tube. You may have to protect the tube from other responders. The fire crew on scene, the police crew on scene, the nursing staff.
The ER staff.
The ER staff's a big one. They'll snatch that tube out and then blame you for not having one. That's why I said always have your capnography reading ready to go. And another thing is, if you come in there with an eye gel, they're gonna do what? Take it right out and try and intubate. And you can bet that if I have an eye gel in a patient, it's because I couldn't get the intubation. It's always satisfying watching them not get it too. But they have things I don't have, like real good video laryngoscopes that put it on a big screen. That's super nice. They got advantages. They have a lot more staff, a lot more help. There's several doctors to bounce ideas off. Great lighting is a huge thing, because I don't know if you've seen the light on this bad boy here, but it ain't super great. Better pay. All that mess. So it's just not that great. So how can I measure the effectiveness of my interventions in regards to airway management? What do you think there, Raph? Maybe if you put your phone down. Maybe if you quit looking at it. You know what? You paid to be here. I don't give a fuck. You do what you want. Oh, God. I'm on recording again. Measurement of the effectiveness of my interventions in regards to airway management.
Ventilation, capnography, listening to breath sound.
So we're saying that capnography, patient's color, can I see chest rise, lungs and tidal volume, how much effort it is to recompress the bag? What does that mean? Airway compliance. So are you seeing changes in the end tidal CO2? Can I see good waveforms? I showed you examples last week of what? Hypoventilation, hyperventilation, bronchospasm in the presence of asthma causing the shark fin. I also showed you where there was incomplete alveolar emptying, where it didn't return back to baseline because there's CO2 narcosis and trapping going on. Be a little bit gentle with yourself. You're not going to know how to read capnography night one. But there are some things that are pretty obvious, right? There's two giant spikes, or excuse me, two giant rectangles here, and they're going up to like 60. That means they're breathing 2 times in a minute, right? And the capnography is at a 60, right? That's showing me they're hypoventilating. That's bad, okay? Drugs are bad, okay? So how about some more? Is the patient's level of consciousness improving? Are they starting to wake up? How would I catch that? I'd go back and check their what, Gabe? Pulse is good, but how can I check if they're waking up? LOC. Go back to LOC. We go right back to the top in a cyclic review panel. LOC, ABC, interventions, vitals. And then we go right back and circle to the top again. Yeah. They're trying to grab that tube and pull it out and extubate. So just be careful and watch them. If they're starting to wake up, consider some sedatives. There's a reason they went down. I don't want them to repeat the effort. They probably need to be under airway control until the reasoning could be fixed and found, right? So a lot of that diagnostic stuff cannot be done in the ER setting. So we're going to try and keep them down. So what can I sedate them with? What do you think they're... Versed? It's a good one. Ketamine if you got it. What else? Maybe you're a National Registry paramedic. Benadryl. What? No. Still not a sedative.
Ativan or Valium.
Ativan, Valium. What else? How about etomidate? Etomidate. Why would I choose etomidate versus something like a Versed or a fentanyl?
More hemodynamically Stable.
Very good. So etominate doesn't mess with the blood pressure. A lot of Versed, it's going to drop the blood pressure. You have to be very careful when giving sedatives because it can drop the blood pressure. Any kind of respiratory drive they got, it could knock it out. So hypotension is one of those killers of intubation. Remember that HOP? We said it earlier. So be very careful with that. Now, let's talk about the failed airway. Anytime you've tried an IV, if you've done IVs in here, you've missed a few, right? You're going to have airways be the same thing. I don't care how good you are or whatever. There's going to be airways that you cannot get. Let's talk about it. A failed airway is failure to maintain acceptable oxygen saturations during or after or on more failed laryngoscope attempts. What does that mean? A failed airway is when you cannot maintain an O2 sat. They're continuing to get worse. You've tried to intubate. You cannot do it. So what's the plan, man? If you cannot ventilate, you need to try and intubate. If you cannot intubate, you need to try to ventilate. Worst case scenario, you must criconate. So this came from the New Orleans EMS, obviously. Like I said, I brought this lecture together through tons of different research, tons of different modalities, different places and spaces. This came from theirs. They give their intubators 3 attempts of oral tracheal intubation. 3 attempts by an experienced intubator. What does that mean? Somebody that knows what the heck they're doing, that's done this a while. Not you, brand new. No, not they're finally somebody picked it up. Not you, the brand new paramedic or the paramedic student. I would advise you to stick with 2 times. Now you got to make that choice yourself out there in the field. Make that choice yourself. But even I keep myself to 2. Boundaries are important. Putting boundaries on yourself is important too. So I gave myself a boundary through the years. I get 2 attempts and then I'm going to an IGEL. But again, those 2 attempts are what? Different blades, different techniques, different tubes, different all kinds of things. Making a plan and then changing the plan. My first look in there is going to be what?
Visualization.
It's going to be me taking a look at all. That's just laryngoscopy. I'm just going to take a look, then make a plan. Pre-oxygenate for me.
Okay.
Yes, there are people online. Yes, we can hear you. There, mute yourself. We've heard their little whispers this whole time. So the difficult airway. Not all airway management failures are avoidable or predictable. That's just kind of the nature of the beast, man. It's just you can't predict everything. You can't avoid failing. I can tell you this, though. Success is not guaranteed. But failure is guaranteed if you don't even try. So give it a try. Attempt to minimize your failures and have a backup plan. Again, I would prefer to walk in the ER with a perfectly packaged intubation every time. But I am not here for my pride. I'm here for patient advocacy. Explain, Sloss.
You are to act in the best interest of your patient when they cannot do so
For themselves. Best interest of the patient. So difficult laryngoscopy. It's hard to see things in intubation. I can't intubate, but I can ventilate. Or I can't intubate and can't ventilate. I have to try one or the other. Is there a dislodged tube? Is there an obstruction? Is there a pneumothorax? Is there equipment failure? You know, some of you of the Maltese cross wearing variety have equipment that just rots. Why? You don't use it. Not because you don't have the opportunity to. It's just y'all don't use it. And that's not a jab at you. I love jabbing at you. Don't get me wrong. But it's because let's say you got an ET tube. You pull it out. Nobody at your station's intubated in years. This thing's probably dry rotted. Like you've probably seen some of the equipment's like dry rotted or old or expired. And the seals on that cuff, it won't inflate. And you're sitting there trying to intubate. Why ain't it working, man? Because it's out of date from lack of use. Whose fault? If it doesn't inflate, it's not going to work very well. Why don't you just use one that is working or is in date by checking your crap off? Oh, y'all quiet now. Huh? Do better. So plan B, bag the patient. Maximize the neck flex. What's that mean? Throw that thing way on back. I told you my little trick I like to do. One of my favorite things to do was to lay down in sniper position on the ground, pretty much prone, and then have the patient's head fall off the back of the stretcher. That gave me complete visualization of, I could see all the way down to their toes, just about. It works very well. So move the tongue out of the line of sight. How? We enter in the left side of the mouth. We sweep the tongue, lift up on that area that we're trying to move. Either it's a Mac blade or a Miller. Miller doing what? Lifting the epiglottis directly. Mac vallecula indirectly lifting the epiglottis. We're going to ID landmarks, adjust the blade, throw the Burt maneuver in there, backwards, upward, rightward pressure. Increase lifting force. What's that mean? Really crank up on it. Don't switch back. Don't flop back, but push up higher, lift up higher. There's been patients who I've actually picked their top half of their body up off the stretcher or the ground or whatever that I was lifting so much. Maybe consider the Miller blade. A lot of people's first go-to is not the Miller because it is more dangerous and can bust teeth. Or come back and bag the patient again. So you use the optimal sniffing position. How about we talk about changing the length of blade? At least change the length of the blade one time. How about changing the type of blade one time? So if you couldn't get with a Mac 3, go with a Miller 4. Change some things up. How about we give way to a reasonably experienced laryngoscopist? What does that mean? That means I have the humility that I'm working with, Sloss is working with me today, right? And he's the paramedic and blah, blah, blah. And I'm just his old paramedic partner, but I'm the new medic. I got to get this tube. He might have a hesitancy to do what? Let me try, because he's the new medic and he wants to prove himself to himself and everybody else and blah, blah, blah. Is it about him and his ego, though? No. So here, you give it a shot. You give it a shot. Let the other paramedic on scene do it. Maybe he's more experienced. There's a thing about experience, man. You can't beat it. Same thing with IVs, yes. So the first response to failure to intubate should be to bag the patient. As soon as you can't get that airway, go ahead and bag. So the first response to a failing bag of the patient is to better bag the patient. What does that mean? Do a better seal, reposition, move the head, maybe put an OPA in or an MPA. Some of you are like, I'll never put that in there. Why? Why not move the tongue out of the way and hold it out of the way? Why not form a secure pathway for air to flow? Why not? So, failed intubation. 3 failed attempts by an experienced intubator. A lot of places or a lot of literature, and again, this came from the National Airway Management course. So they're saying 3. For you, I'm saying 2. When you get out there and you do your thing and you got some experience, then we'll say 3. 3 attempts by an experienced intubator. Most of you are not experienced intubators. Give yourself 2. Or inability to ventilate or inability to oxygenate. What's the difference in oxygenation and ventilation, Dabney?
Oxygenation is giving oxygen to the person. Ventilation is moving the CO2 out of the person.
All right, so ventilation is moving air in and out. Oxygenation is putting more O2 molecules in this patient's system. So if you can't intubate but can ventilate, you have some options. How about light guided technique? Lighted stylet. What's a lighted stylet? It's exactly what it sounds like. It's a little plastic tube that you can put it through your ET tube, and it's got a light on it. It helps to guide you. Combi tubes, LMAs, fiber optic stuff. Ooh, y'all ain't got none of that. Retrograde intubation, cricothyrotomy. That's really old stuff.
Yeah.
You wouldn't be doing that. I don't remember. Quit asking me stupid questions on camera. Look it up. I forgot. Because it's stupid. I don't do it.
Yes, sir.
You're stupid. I hate it. Quit asking me stupid questions. I don't know. So what else? If you can't intubate, can't ventilate, you must act immediately. Let's say that again. You cannot intubate. You cannot ventilate. Now it's time for a cric. It's time for a percutaneous transtracheal jet ventilation. What is that? So you'd still do the cric, needle cric. Then you hook a machine to it where you hit a button and it shoots air in there, shoots pure oxygen, and it can inflate their chest. Haven't seen one of those pre-hospital in a long time. Combi tube, LMA, these are your options, guys. The difficult airway kit, multiple blades and ET tubes, ET tube guides, stylets, bougie, light ones, emergency non-surgical ventilation. Remind me what retrograde is?
You're going through the nose. One is going through the nose, one is also talking about once you get.
It's like using a bougie.
Yeah, it's like, but also you gotta cut the wire off.
Interesting.
I got a picture right there. I got a video.
It is confusing. That's why I didn't remember it. So emergency non-surgical ventilation, we've got emergency surgical kits.
Oh, it's, you put a wire through and like hold the ET tube in backwards.
So we stab through here
Yeah.
with a wire. We stab through the trachea.
And go outside.
I remember why I didn't even bother committing that memory because we're not doing that. Quiet. So in your difficult airway kit, you've also got surgical crike stuff. ET tube placement verification. This is all the stuff that you need to pull out. So whenever you go to do an intubation, you set yourself up for success. What are we doing? Lay everything out. The blades you think you'll need, the blades you might need, the ET tube you want, the one above it, the one below it, your crike kit, your LMA, your King, or your iGel. Have it all ready to go. So it is preferable to use superior judgment to avoid using or having to use superior skill. What does that mean?
Make stuff easier about thinking. Work smarter, not harder.
Work smarter, not harder. I may take a second look with my laryngoscope blade before I intubate because I want another look. The whole crux of this advanced airway lecture was what? To make a plan. We said in last week's last lecture that the American Academy of Anesthesiologists or whatever, they said what? The way that you can best predict a difficult airway and to achieve intubation success is to prepare and make a plan. You ready to intubate? Who do I want? Baker, you're up. You ready? Go ahead and intubate. He's alive.
He's alive. You can see it.
Every time he breathes, you see bubbles.
Suction, right? I mean, God damn.
I'm recording.
Oh, sorry, Jesus Lord. Suction.
Suction, okay.
Um,
You see his tongue there? That drool?
sedated? Or do you-
You tell me it's your patient.
I can kind of see the problem.
So this patient did what? Shotgun. And he just blew the front half of his face off. He didn't get the brain, so he's gonna live.
You want to
Give him the shotgun back.
Just give him the shotgun back. Finish him.
I got you.
What's on your mind? I want you to save him, Baker. Do something.
Suction, use suction, I'm a part of continue the suction as oh. That's right.
But that shouldn't be effective though, cause it's not like he's bleeding.
Yeah, all right, but
It's like, it's
trauma, we got trauma intubate, I'll put them down.
You gonna intubate? How you gonna intubate?
notches.
It all starts with.
What method? What blade?
Oh.
You gonna let him stay awake?
Okay, I get what you're saying. I use I probably use a mill for this one.
A mill. Okay. Look at him using all short term.
Huh?
Look at you using shorthand.
Yeah, it's like that,
Like he's
don't take the long
experienced.
term. So I use a mill for him. And then I intubate, pretty much.
Are you gonna lay him flat?
I don't know, cause he fucked up.
You might have to do that.
He's not. in his-
You quit saying the word fuck, please.
I was. Stop saying- You don't have any spot. Yeah, no. Hey, bro,
Manage your patient.
I'm manager. man.
Managing to kill him, yeah.
Yeah, so.
Yeah, I would get a bougie and let it down.
I would get a bougie, guys, actually.
Hey, all right, here we go.
Okay, okay. All right, we ready? All right, put some bass in you boys. Make sure it's on recording now. Hey, baby, what's going on?
Section, my part. Section, continuous section, I use a mill for him. I would lay him on his back temporarily. If he's not included with blood, if my partner is going to do enough suction, we should be okay.
Yes,
Sats are
ma'am.
dropping,
Huh?
sats are dropping,
That's the dropping.
You're taking too long.
So, I did that last time. But then I could pre-oxygenate, but last time I did that.
How you gonna pre-oxygenate?
Yeah, exactly.
Where you gonna put the mask to seal?
Yeah.
Yeah.
He done blew it by his face.
Yeah. Hold on, is his nose just underneath the flap of skin that's there? Is his nose on? No, you don't have.
Probably don't feel shit. You really need to.
What I'm just saying, you're gonna fix the face right there. It's a lot of brown.
He's awake.
Yeah, so he's gonna get some.
You don't feel
Sir, I just knock him out. Say that. What is that?
Okay, knock him down. I like it so far.
Knock him down, that's why you.
No, you can knock him out.
Knock him in the first there, pretty much. I mean, this shit hit wild, I mean, excuse me. This is a wild patient. I thought I would get something more. Yeah, so innovate with the patient.
He's probably dead by now, yeah.
Yeah, you was my partner, maybe.
Ooh. She said if I was there, I'd have done intubated and been done on the road.
Yeah, so we did.
So what we do is, here's what we're gonna do. Where's Grady? Please hurry. This is your patient. You're on an engine. Grady's 20 minutes out because they're level 0. How are you gonna manage him? Paramedic Baker on engine, ALS engine, whatever.
So.
You got 20 minutes of managing him. Does he have 20 minutes? Mm. Good guess. He's got 8.25 minutes. Okay.
Up there, suction it. We put him down. I intubated. Give him oxygen. Kind of vent. I'm able to vent with no.
If you intubate him, you should be able to ventilate him pretty well. As far as ventilating him and pre-oxygenation, all that's out the window. I would sedate the living crap out of him. I want him out and gone. I see his tongue hanging out there. So I'd either do a tomahawk method where I'm standing in front of him face to face, grab it and pull it down. I'll show you that today. Or I'm going to go ahead and try and just take him through the normal intubation means, but I'm not going to fail in this airway. Worst case, he gets some kind of crike. What you got?
So you saying face to face? Are you laying him on his back or are you sitting him up?
He's sitting.
Sitting up, you know,
I'm gonna sit him up so he can drain. Then as he sits there, I'm gonna actually probably duct tape one of these things sitting up here a little bit. Face to face, he's sedated. I'm gonna have him sitting up like this, and I'm gonna come at him like this. Like I would be coming at Sloss. I'm not gonna stab him. Come here. And I'll grab that thing right there and I'll pull down like this. This is a tomahawk method. Catch him right here, pull it down, intubate that way. On him, there's nothing in your way. You would see everything. Because I can see his tongue right here. So look at him right here. See that right there? I'd grab back in there, I'd pull that bloody stump back, and I'd be able to find that glottic. Basically, you don't have.
You give him fentanyl, please.
Probably.
I don't think more.
I don't.
I mean,
Dave,
should have said it. I was gonna say that.
you give him like Versed and fentanyl. Could you lay him on his side?
Put him down, do I have to give him pain?
Yeah, Versed.
So wait, if I give him birth I put him down, I still gotta give him,
Versed don't provide pain.
if he's down, he's like, still gotta.
Your body doesn't have a physiological reaction
Yeah.
to pain.
Alright. Appreciate it.
And I
How
wonder
would
what
you
was
secure
going
the
through his
airway
mind.
in that situation?
I like it.
Well, I would secure the airway just because you want to secure the airway for that situation.
It'll fall out. If you don't secure it somehow, it'll fall out. You can't use a commercial tube for him.
How would you do that?
Oh, let me ask my question. Are you saying intubate just because he's going over intubation for that patient?
No, he needs.
He's gonna drown in his own fluid. You saw how much was coming. Let's go back to him.
Yeah, that's what I'm saying. You saying intubate because he's going over intubation or what? Because if right now,
If we did intubate him.
right now, chill out, chill. I want Dr. to ask my question. Right now, if I pull up on scene, this patient, yeah, you can't see nothing going on. You can't see. But if his chest is rising forward and he's moving air, there's a big hole in his face. There's a hole in his face, he can be breathing. So are you just saying intubate him because we're going over innovation? Or you just, you would really innovate this patient?
So-
It's a big ass hole in his face, so he could be breathing fine.
Right.
Yeah,
That's what
he's
I'm
conscious and leaning forward.
Yeah, if he can't, but he'll wait, he's sitting up in the hospital somewhere. So he didn't get innovated to get wherever he at unless he killed himself in hospital. I mean, he shot himself in hospital.
It's
That's what I'm asking
though.
you. Are we going over innovation just because you want to talk about it? Or would you just innovate this patient just because?
You know-
With the hole in his face.
That's not a bad question. So if it ain't broke, You ain't gotta fix it. You just have to maintain it. I get what you're saying. This guy right here, see all that blood coming out right there? As long as he can lean forward, it'll be okay. But the amount of blood he's losing, the blood that's going in his airway, he's going to deteriorate. On scene with this, he probably wouldn't last very long with you. I would say, I am saying this for intubation purposes because I'm going over intubation. That's what I base it off of. But could you, if he can maintain his own airway and blah, 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 because he's got a giant hole there, that could be an idea too. But my thought process is that he's probably going to deteriorate on scene with you. And if that's the case, we're getting Baker to go ahead and take care of that for us
All right, thank you.
with sedation, with pain management, with some form of intubation.
Yeah, go ahead.
He is also going to experience hypovolemia. Do you see him on the blood that was coming out of his mouth? So let's talk about some other options. Oral tracheal intubation with video laryngoscopy. How about a video scope? Or as we call it, sorcery. Ooh, that magic stuff that y'all ain't got, or you got that you don't use. It makes your life very much easier. And it's also an idea, just an idea, hear me out, that if you can't get the tube by normal means, you then do what? Oh, she couldn't sit over the chair? She could also, she could sit in that chair and then not have to worry about it. Oh, okay, she wants to sit next to Dad. Fair. So if my first attempts with old Ironsides here have failed, perhaps with my second or third attempt that I'm giving myself, I could try something off the wall, like a device that has a video camera that shows me exactly what's going on down there. You know, it's a crazy thought. What is your question? Most of them are Mac, but I guess some of them could come in Miller style. I've never seen one though.
So in that situation, were you okay to use a Mac too, or just the
What?
The tomahawk Mac? Is it okay to use a Mac?
You're probably gonna want to do the Mac blade, the curve. So you've got video laryngoscope options. They're very fancy nowadays. Some of them can actually take pictures, dim the light, increase the light. They can they can actually Bluetooth and send the video of you intubating to the ER. There's a lot that can do. That's pretty cool. Nasotracheal intubation, indicated for a breathing spontaneous patient that requires definitive airway management. Contraindicated when apnea, head trauma, and mid-face fractures. Why? Because you could stab them in the brain with the ET tube. Okay, that's bad. Anatomic abnormalities or frequent cocaine use. Why? Yeah, the nasal membranes are pretty messed up. So any little kind of scratch or any kind of nick in there could cause a deep bleeding there. Nasotracheal intubation can be performed on responsive patients. No need for a laryngoscope. Mouth does not need to be open, does not require a sniffing position. Patient cannot bite the tube. It can be secured very easily. I can tell you where it came from. Back in the day, we used to nasotracheal intubate patients because we didn't have CPAPs. So a patient with CHF, bad exacerbation, you'd intubate through the nose. And then you would add positive pressure ventilation with the bag. That way you could actually get some positive pressure down there. They have to be conscious. And you also have to have a special like stethoscope so you can hear air moving through that thing. So you know you're in the right spot. Because it's kind of a blind intubation. Kind of. Disadvantage is it's a blind technique. There's no confirming proper tube position, requires good diligence, and it could cause a lot of bleeding there. Ugh. So technique for nasotracheal, I'll let y'all try it today. Yeah, man, it's going in there. Get in there. Hell yeah. Yeah, you got to be awake.
That's torture.
So it's kind of like inserting a nasal trumpet. Insert the tube in the nostril, bevel facing toward the nasal septum, aim the tip towards the back ear. Please lube it. There's always time to lube the tube. So. All right, digital intubation. This is when you digitally, by your fingers, palpate the glottic structures, elevate the epiglottis with your fingers, and then you guide the ET tube through the trachea. The times that I did this, it was a car wreck, crushed car, patients losing their airway. I can't actually get behind the structure. I can't actually intubate, so it had to be that or nothing. So how do you do it? Finger bang their throat hole.
I was gonna say, would that be an option for that guy that's shot himself in the face?
Actually would have. Here's another picture. Does what it's told. Does it enjoy?
Walk your fingers.
His fingers? Here, eat this banana.
So at this point, you're not worried about the money
Yeah.
there.
He said in the car.
Extreme circumstances. That guy'd be fine. He don't have teeth.
Teacher Josh, wait, what fingers do you use? You use the index in the middle? Okay.
Index and the middle finger.
Alright.
Those will have the most dexterity, also tensile strength as well. All right, so these are advantageous in the case of equipment failure. Primary disadvantage is you're putting your fingers in a patient's mouth. So there is a possibility that they could bite you. So absolutely contraindicated if patient is breathing, not deeply unresponsive, has intact gag. What does that mean, deeply unresponsive? Dabney, what you got?
They gotta be out.
Out, like super out. Because if they wake up and just have a reflex,
Yeah.
there goes your fingers.
Yeah.
Major complication is the misplacement of the ET tube. Why? You can't see, it's blind. But it's better than nothing. But it ain't gonna do any good if you just put it in the esophagus. All right, so I'll actually just show you how to do that physically here in the lab today. Any questions about that? What's your question?
So are these blind techniques, do they come before like a needle crack or they crack the last option or blind technique the last option?
For me, the surgical crack is gonna be the last option. Like the digital intubation, the times I did that again, it was very, very special. They were out, they were losing their airway, pretty much a traumatic arrest almost at that point. And that was just that was just a last ditch effort kind of thing. So the face-to-face, paramedics face at the same level, head is stabilized, not in sniffing. Laryngoscope can be held in the right hand, E-tubes in the left hand. This is the one time it changes. One blade is placed, head may be adjusted by pulling the mandible forward. So basically like this, and pull it down, intubate, pull it down, intubate. Questions on that? We'll practice it here in a minute. So the failed intubation, have a different plane every time you try and have a rescue adjuncts ready if you fail. Again, failure to maintain oxygen sat during or one or more attempts is a failed airway. If you can't keep the sats up, you're failing. Now, if they're apneic and they're in cardiac arrest, still consider, giving yourself a time limit and a time frame before you swap over to what? iGel or something else. Give it a shot, guys. Just give it a shot. All right. We're liking it.